Thanks for the intro, Sue. If we can go to the next slide. So for the learning objectives for this presentation, we're hoping to discuss considerations for diagnosing concurrent mental health and substance use disorders, describe general principles, risks, and challenges treating concurrent mental health and substance use disorders, identify the role of primary care providers in managing concurrent disorders. Next slide. So what are concurrent disorders? So as you can see in this Venn diagram, folks might have mental health disorders and substance use disorders. And when you have both, and as you can see in the intersection here, that's when you have a concurrent disorder. So the important aspect of this is that when you have both conditions simultaneously, it can actually make the prognosis worse. One of the most important things to take away from this talk would be that concurrent disorders are the rule, they're not the exception. So most of the time when you see folks with a mental health disorder, you're going to see substance use disorders, or when you have folks with substance use disorders, you're going to see a mental health disorder as well. So always look for one when you see the other. If we go to the next slide. So for concurrent substance use and mental health disorders, we need to look at the prevalence. And an important thing to look at is the overdose data that the coroner had in the report in 2017. And what they found was that 52% of the folks who died of overdose that year had a diagnosed or suspected mental health disorder. If you look at specific populations, like the downtown east side, there's the hotel study. And what they found was that 95% of the folks in the downtown east side had a substance use disorder, 74% of them had a psychiatric disorder, 47% of them had psychosis, and 45% of them had brain injury. So there's a huge overlap between these three things, substance use disorders, psychiatric disorders, and brain injury. If we can move to the next slide. So there's common things that can occur with all of these disorders. So when you have, like, say, major depressive disorder, the most common concurrent mental health disorder among individuals presenting with substance use treatment. And so this could be 15 to 20% of the folks who have this. You can also have things like anxiety. There's a massive amount of trauma in this group. And so you can have post-traumatic stress disorder and also insomnia. Now, there's studies that are looking at this, and an important thing to differentiate, and we'll go into details about how to do this later on in the presentation, is which ones of these symptoms are substance induced and which ones are intrinsic organic psychiatric disorders. So there was a study that looked at folks that came into addiction treatment rehabilitation centers. And based on the brief severity index, they found that 39% of these folks had psychiatric symptoms. So these would be depression and anxiety, things like psychosis. But what they found was that 1 month into sobriety, this dropped to 3%. So there was a 13-fold decrease with sobriety. So part of what needs to be done when you're trying to diagnose a concurrent disorder is to see which symptoms are intrinsic organic psychiatric symptoms and which ones are substance induced. Next slide. So for dealing with this population, it is a diagnostic challenge. So there's, as I was mentioning, there's a significant overlap. And so as a result, concurrent disorders are often undiagnosed and undertreated. Now, why is that? Well, one thing to look at is protracted withdrawal. So if you look at, in the treatment community, they'll call it post-acute withdrawal syndrome. So when folks are using substances for an extended period of time, they have changes in their brain that will produce symptoms. So I'm going to get a bit tangential and I'll bring it back. So imagine astronauts going up into space. They lose bone and muscle mass. Why? Because their body is saying, well, why do I need all this bone and muscle if I don't have all this gravity to fight against? In the same way, when you stimulate the reward centers in your brain to levels not found in nature, your body's going to say, well, why do I need all these dopamine receptors in my brain? As a result, you're going to get things like anhedonia, which is an inability to experience pleasurable activities. And so one of the most common things that I hear from my patients is, doc, I stopped using, why don't I feel better? And one of the things is when you stimulate your reward center and you lose dopamine receptors there, you're not going to be able to experience as much pleasure from regular activities. You're also going to have issues with concentration because another place where they have dopamine receptors is your orbitofrontal cortex. You're also going to have issues with sleep. So when I did my addiction fellowship, one of the fellows was looking at sleep, and what he found was that there were EEG changes, so changes in brain waves 18 months out from your last substance use. And what is the timeline for recovery? Well, you're going to have your symptoms worse 3 to 6 months into recovery. You're going to start getting recovery 8 to 10 months into recovery, and you're not going to reach your pre-morbid level of functioning, so before you had a substance use disorder, until 18 to 24 months into recovery. So the time to recovery takes months to years. It's not something that gets better in hours or days or a 30-day program or a 90-day program. As a result, these are often undiagnosed and undertreated. So there is a link between substance use disorders and psychiatric disorders. And to kind of flesh out this cycle, I'm going to use the example of cannabis. So there's a link between psychosis and cannabis. And what they found in Nordic countries was that 40% of the folks who came with a cannabis-induced psychosis would eventually develop schizophrenia. Now, there's 4 different theories to these. One is it's a component cause. So cannabis might be something that causes schizophrenia. Another, not by itself, but along with other things. Another thing is there might be a common genetic risk factor between the two. So something genetically that will cause you to have cannabis disorder will also make you have psychosis. Another theory is that things like cannabis might bring on the symptoms earlier. So someone who would already develop schizophrenia might have earlier symptoms because they were using cannabis. And then the 4th theory is reverse causation. So someone might have symptoms that would be treated with cannabis. So for instance, with cannabis, with your verbal reasoning, you would increase your dopaminergic function and have some improvement with that with things like cannabis. So people might be treating symptoms of an underlying mental illness. So there's a cycle and a connection between all of these. We can go to the next slide. So what do we do with this population? So it's important to take a trauma and violence informed lens when looking at this population. So substance use can be difficult to talk about due to past experiences of stigma, discrimination, and trauma within and outside the healthcare system. Trauma and violence informed approach helps create a safe and supporting setting for all people. So the key principles of trauma and violence informed practice are: 1, trauma awareness. So there's a huge amount of trauma that's experienced by folks who have substance use disorders. And because of stigma, they can have issues with safety and trustworthiness. So you want to take the approach of choice, collaboration, and connection with the folks that you're treating. And you want to take a strengths-based approach and skill building so that people can help get to the goals that they want to reach. If we can go to the next slide. So how do we diagnose substance use disorders? Well, the main standard that we use in North America is the DSM-5, and the latest edition is the text revision. So an easy way
to still technically did your job.
Sorry? Okay. So there's 4 C's that you can think about with addiction. So compulsion, control, like loss of control of the substance use, cravings, and continued use despite negative consequences. Along with this, you can have the physical issues like withdrawal and tolerance. Now, depending on the number of symptoms, so there's 12 symptoms for substance use disorders. If you have 2 to 3, that's a mild substance use disorder. If you have 4 to 5, that's moderate, and 6 or more is considered severe. So you want to assess for mental health disorders if someone also has a substance use disorder, as I mentioned earlier. Next slide. So you want to differentiate between potential and clinical pictures. So you want to see, are these symptoms coming from intoxication or withdrawal, or as I mentioned earlier, protracted withdrawal? And you want to see, are these symptoms substance-induced or intrinsic organic primary psychiatric disorders? So one thing that you would look at is in your questions during your history, is there a pre-existing mood disorder? So you'll see in the case, the person that I had, he had depression since the age of 14. You want to see, is this a substance-induced psychosis? Is this a pre-existing psychosis? Is this a combination of 2 of the above? So folks who have psychosis, like a psychotic disorder like schizophrenia, if they take a stimulant like crystal meth, they might actually get a worsening of their underlying psychiatric disorder. So it might not be one or the other, it could be both. If we can go to the next slide, yeah. So, diagnosing concurrent mental health and substance use disorders is challenging and requires a thorough assessment of the client. Clinicians should consider the sequence of symptoms, the timelines of symptoms, and drug use. Symptoms present during any periods of abstinence and other strategies to help diagnose concurrent mental health and substance use disorders. So, you want to look at their substance use history. So, you want to know when they started using the substance and if they meet criteria for a substance use disorder. You want to ask about family history. So, certain things like psychosis can be really prevalent for folks who have a history of psychotic illness in their family, especially first-degree relatives like parents or siblings. You want to look at their pre-morbid history. So you want to look at the age and onset of their symptom pattern. Temporally, you want to determine the order of the onset of the substance use disorder versus the psychiatric or medical illness. And you want to look at their psychiatric history. So you want to consider any previous diagnoses, the temporality with substance use and symptoms during periods of abstinence. We can go to the next slide. So you want to look at confounding variables. So you want to determine whether the person has had continued presence of psychiatric or medical symptoms during significant periods of abstinence. So as I mentioned earlier, you want to look at periods of abstinence of 1 month or more. And this might be hard with some of the patients that you might have. You want to look at the typology of symptoms. So you want to consider the types of symptoms and do these substances cause these symptoms? For instance, you're not usually going to see symptoms of mania with opioid intoxication. So that might be one thing that might differentiate whether someone has an intrinsic organic underlying psychiatric disorder. You want to look at the severity of symptoms. So you want to consider this severity even during periods of abstinence. So during times of abstinence, do these symptoms increase or decrease? You want to look at collateral history. So you want to obtain history from family, friends, case managers, and treatment providers as appropriate. And it's good to look at objective data like urine drug screens. So for instance, when I was in residency, I had a patient that came into detox, and the patient was withdrawing from, at that time, oxycodone and cocaine. And the only medication the patient was on was lithium. And the only diagnosis they had was bipolar disorder. And what I found was that the treating physician had never done a urine drug screen on the patient. But you could see how if someone was using cocaine, they might look like they're manic. Or if they're withdrawing from things like cocaine, they could look like they have depression. So it's important to screen for these things if there's a suspicion. We can go to the next slide. So you want to make sure to rule out medical issues like using a physical exam. So look for classic symptoms of substance use presentation like liver cirrhosis in individuals with alcohol use disorder. As I mentioned earlier, you want to do urine drug screens, especially if you think it's going to result to clinical management. So like the example that I gave, if you'd have known this person was using cocaine and oxycodone, you might not have put them on lithium. You want to get multiple sources of information. So don't just rely on patient self-report. Use collateral information, physical examinations, laboratory tests, and formal structured or semi-structured interviews. And you want to do serial longitudinal assessments to see how the symptoms change over time or how substance use might affect these symptoms. Then for clinical tips, avoid making psychiatric diagnoses during periods of intoxication or active withdrawal, as symptoms of intoxication withdrawal can be challenging to differentiate from psychiatric symptoms. So as I mentioned earlier, there was that study that looked at folks that came into rehab. 1 month into sobriety, there was a 13-fold decrease in psychiatric symptoms. So try to look more during periods of sobriety, and a good rule of thumb would be 1 month of sobriety. And when in doubt, consult with psychiatry or addiction psychiatry if available, if a client displays psychiatric symptoms while intoxicated or in acute withdrawal. So what would be the general symptoms of all of this? Well, one, treat both disorders at the same time. So the best evidence that we have is not to treat the substance use disorder first and then treat the psychiatric disorder, or treat the psychiatric disorder first and then treat the substance use disorder. You want to treat them simultaneously. You want to treat them concurrently. So for instance, I work at Redfish Healing Center, and the most common psychiatric disorder that we treat there is schizophrenia, and the most common substance that people are using there are amphetamines. And what we found is that in our population, when we use clozapine, we found that there's been a reduction in their psychiatric symptoms as well as a reduction in amphetamine use. You want to avoid undertreatment. So failure to treat one disorder can negatively affect the longitudinal course of the other. So for instance, if someone has an opioid use disorder and a psychiatric or psychotic disorder, it'd be difficult for them to get to the pharmacy to get their methadone if they're psychotic. So you need to treat that. You want to avoid overtreatment. So during assessment, consider that some mental health symptoms could be substance induced. You want to offer medication that has potential to treat symptoms of both mental health and substance use disorders. So I mentioned the example of clozapine earlier. You want to recommend a medication that has the least potential for dependence. So, for instance, someone might come into the ER and they might be psychotic and agitated from amphetamine use. And it's okay to use benzodiazepines acutely for rapid tranquilization, but you wouldn't want to use benzodiazepines in that population long term as it can cause iatrogenic benzodiazepine use disorder. You want to work with the individual to create a plan to support treatment and engagement with ongoing monitoring. You want to involve family members and case managers as appropriate, and you want to offer linkages or referrals to psychosocial treatments or interventions such as counseling or cognitive behavioral therapy, as well as community supports and harm reduction services or peer support programs as appropriate. Next slide. So what are some of the challenges? Well, one is the need for integrated treatment. It might be very difficult to find integrated treatment in the community that you're in. Another is diagnostic complexity can lead to false diagnosis and improper treatment. So one really big example of this is the diagnosis of ADHD. So as I mentioned earlier in protracted withdrawal, one of the core symptoms of protracted withdrawal is difficulty with concentration, and that might be confused for ADHD. You want to balance the risk of treatment versus non-treatment. So you want to include pharmacological treatments, psychosocial interventions, peer-based support, and culture-based interventions as appropriate. Some individuals may be open to some of these treatments and not others. So you want to look at the risk of medication effects combined and the combination of medications, which could worsen symptoms. So one thing that we looked at Redfish and was kind of a replication of a result out of St. Mike's in Ontario was the use of stimulants for folks with a history of psychosis. So what we found at Redfish was that when we provided stimulants to treat ADHD in folks with a history of psychosis and stimulant use disorder, you actually increase the psychosis and you increase the stimulant use disorder. There could be a difficulty in measuring the effectiveness and treatment adherence because there's such an overlap between the symptoms. There can be difficulty in medical and metabolic monitoring. So I mentioned the example of clozapine earlier. That's really hard to do on an outpatient basis if you're a primary care provider. And then there could be considerations for the social determinants of health. So there's things that are just really difficult to fix. I think something that we're experiencing all over BC is housing of folks after they leave treatment. So we could have really great treatment, but once they get discharged, they might not be able to find housing. So for the overall treatment goals, the main thing to keep in mind are concurrent disorders are the rule, not the exception. So applying these principles, you want to have acute stabilization of both the mental health and the substance use symptoms. You want to achieve remission for both the mental health and substance use disorders. So you want to reduce the resolution of symptoms. You want to attain client-identified goals around functional capacity. You want to have prophylaxis to avoid return to use of the psychiatric distress. You want to optimize treatments for both of these issues. You want to re-engage in previous activities. There was a reporter, his name was Johan Hari, and he coined the phrase, the opposite of addiction is not sobriety, the opposite of addiction is connection. So you want to try to reconnect these folks to family or people who they regard as family and improve quality of life. Next slide. So this is out of the American Society of Addiction Medicine, and it looks at placement for folks and what should be the purview of folks who might be primary care providers. So on the y-axis is the substance use disorder, and this could be low severity to high severity. Then you can also have the mental illness, which could be low severity or high severity. So we want to look at category one, where the mental disorders are less severe and the substance use disorders are less severe. And this would be what we would focus on in terms of primary healthcare settings. So next slide. So what is the role of primary care physicians? Well, one is to build a strong therapeutic relationship to deliver effective, high-quality, person-centered care. Another would be following standard medication management protocols, including considering interactions with unregulated substances and alcohol. Another would be informing clients on potential drug-drug interactions to support safety, integrating mental health and addiction services, emphasizing evidence-based treatments, including psychosocial interventions, collaboratively determine and individualize treatment plans based on resource availability and client accessibility, and take a harm reduction and strengths-based approach. Continuing on the next slide. So you'd also want to address compounding challenges such as homelessness, incarceration, and potential return to use, which can affect concurrent conditions. So Amanda Butler in her study found that the biggest risk factor for recidivism in 3 years is if someone had a concurrent disorder. So if someone didn't have a mental health disorder or substance use disorder, about 49% of folks would have recidivism. But if you had both, that jumped up to 73%. You want to focus on training and education about concurrent disorders for care providers. You want to go beyond referrals to establish formal collaborations. You want to review treatment plans frequently and make collaborative changes with clients to support quality improvement as necessary. And you want to consult or refer to a psychiatrist for treatment guidance when needed. So in summary, diagnosing concurrent disorders can be challenging due to similar and overlapping symptoms. Both substance use and co-occurring mental health disorders should be treated at the same time. Treatment goals should be the stabilization and remission of both substance use and mental health disorders. Primary care providers can support clients through integrated care linkages to additional support and evidence-based treatment. So always keep the other in mind when you see one. So remember, concurrent disorders are the rule, not the exception. Thank you.